please, it was too much.
Yeah, I saw that in the beginning of your presentation, the 3D image. Inside there is a tube. I saw that. What is that? Tube with the fiber.
I think this was the one.
Yes. Yes. What is that? Here.
That is the wire. Because the wire lies outside the imaging probe itself. So that will always remain there as a shadowing, as a small shadowing. Usually it doesn't prevent the whole, I mean the general general evaluation of the coronary artery itself, because it's very thin, as you can see. But it is always there. This wire is very thin. It is you will see it with your hands in the afternoon, but it remains there. So when the OCT lens used to be the image wire itself, in the first generation, it was not there. But since they reconstructed this catheter, it is always there.
So this is existing in our body?
No. This is the guide wire what we temporarily push down in place.
Okay.
Oh, sorry for that. Sorry.
So this is not fiber?
No, that is a metal. This is stainless steel. Very thin, but
because you need it in the other images.
yes. Yes.
Okay.
Whatever we do with the coronary arteries, we need this wire inside. So all intravascular and all OCT, or any kind of intervention, treatment, balloon dilatation, stenting, they are all tracked down on the top of this wire. How should I say this? It's a railing mechanism.
Yeah, I was about to ask you, you have an image where you were commenting on the fact that look wireless here. It was at the beginning, and you also said, and now I serve the OCT probe. So how did you know that?
The OCT
question.
probe, no.
It wasn't here. There was another.
The OCT probe is not there.
There was another slide. You were commenting on the wire, guy's wire. No, it wasn't this.
Yes.
The guy's wire.
This image.
You put the laser pointer.
Yes, this is the one.
No. It was an image from the X-ray camera, and you were showing the wire. And you commented along this wire. Now we introduce the OCT. So my question, something similar, and you're saying now I introduce the OCT probe. And
The optical lens.
no, it's not that one. It was the X-ray image, and you were commenting on the guide wire. Something like this here. And you said, fine, now I introduce the OCT probe. So how do you realize that you introduce the, because you see only the guide wire here.
Yes, but still it can be seen. So there are some markers. There are some markers which shows us. Let me see. Yes. So this is the this very tiny spot. So this longer one is the guide wire. This the very last, the very distal 3 or maximum 4.5 centimeter long ending of the wire of this guide wire.
So this image was 5
This
centimeters.
guide wire, the proximal, it goes up. We introduce it outside. So these wires. Generally, these are about 180 centimeters long. So, because 100 centimeters is the guiding, is the catheter, which goes like this. It needs around, if it's a small patient, only 70 centimeters, but if it's a large, almost 100 centimeters. From the outside to reach the very proximal part of the coronary arteries. So this guiding. From the outside, we introduce inside the guiding this wire, and it needs another 20, sometimes 25 centimeters inside the coronary artery. Can you see? Because this is, I can recognize this is a longer one. This is 4.5 centimeters. Can you see that this is 4.5?
The part that is bolder is darker.
Yes, but this is a continuous wire, 180 centimeters length, and on the top of this
You have the OCT probe,
we have the OCT probe.
and that's why it's less dark.
Yes. The plastic tube in which the OCT probe is spinning and pulled back, almost you cannot distinguish. But there is something. When on this particular image, when there is no contrast, you can see something here. Can you see on the top of this wire? And the very distal ending of this so-called OCT catheter, this plastic tube sheet as we call it, there is a marker. This is a small marker. We need this in order to avoid that we don't, let's say, exceed beyond this point of the wire, but because that is dangerous. Because the very distal tip, it's a little, let's say, how do you call it in English? This is thumb.
Needle, not penetrating.
Not needle, but it's éles angolul. Sharp, not sharp, but how do you call it? Sword. Sting.
Yes. So you don't want to pinch. You don't want to
Pinch,
penetrate the tissue.
Yes. So we need to always to observe where our catheter is. So it cannot exceed this wire, otherwise it's very dangerous. It cannot penetrate. And there is a so-called monorail tube. It is a let's say a previous generation of the catheter. It was around 3 centimeters, so-called monorail segment, which inside this is only meant to be able to track down the catheter to the place, to the distal part of the coronary artery. And
So you could never introduce the OCT probe without wire.
never. And so these are for me, so basic things that I cannot really, let's say, explain it easily. So this plastic tube, this sheet, which contains the probe, the probe, the lens is not really almost invisible. But this bigger marker, that is the beginning of, it is very close to the optical lens. This is suitable for us to really decide where this pullback should start. So if, let's say, this particular part we are very interested in the artery, this marker should be just beyond that. So the optical lens, you cannot discriminate, you cannot identify on this image because it's really not extra marked.
And when you do the pullback, back? Do you pull back only the OCT probe, or do you pull it together with the wire guide?
No, only the OCT probe. The catheter itself remains inside the artery. It's only the fiber optic, little fiber optic core
That which rotates.
that
Only
is
that is
pulled back.
pulled.
Only that is pulled back. So the sheet, this is the sheet, the plastic sheet, which is transmittable for the light. This one is the sheet. You cannot see the probe because the probe generates the image. The sheet, this is the plastic sheet. The outer surface is marked, but it's electronically marked as a post-processing something. This or something. So this is the
So this is the tissue which you see here.
yes.
And these bits,
That
these lines,
these
the horizontal lines.
these lines, the outer surface of the plastic.
Of the plastic.
This is the inner surface of the plastic. This fiber optic cable with optical lens is maybe only half a millimeter. Okay. The whole catheter is just less than 1 millimeter in diameter. That is also one topic which should be improved because it's a very highly stenotic artery. It's much less than 1 millimeter. You can remains, so you cannot cross sometimes. But the real problem is the image generation. So the shadowing, and also that fact that the catheter, this image pullback still requires disclosing the blood with contrast agent, which sometimes still matters, that extra 15 or 20 milliliters of contrast agent is still an extra load for the patient, for his kidney, because this is dangerous for the kidney. And also, this is quite a high pressure. How the dye exits the guiding catheter. It is at least 4, sometimes 5 milliliter per second the speed how we should inject the contrast agent. And this is really, you can feel it, I can show it in the lab, you can feel it in your hand that this is a jet, and maybe also the blood pressure elevation, rapid elevation in this territory can be dangerous when we inject with such a high flow. So this is also a major improvement if you can solve this problem of blood which prevents the image generation inside the blood vessel.
You don't have here an image showing the situation when blood penetrated and you cannot see this. I was having curious to see how that looks like. Before you flushed it,
Yes.
how much could you see from the tissue if that is filled up?
Let me see that maybe I have this image.
Because everyone speaks about the rate of imaging and so on, but that is given without the time taken by the flush, which sometimes may take considerable time.
Yes, sometimes 5, 6. See. But of course, we show those examples when we are perfect with this image generation. But sometimes, and this happens in most of the cath labs, that the first pullback run is not successful. So we didn't disclose the blood. We didn't image all the arteries throughout the legs or what we are interested. So we have to repeat it maybe 3 times, 4 times. So that means that 4 times this 15 liters of contrast, 60 liters of contrast, that might kill the patient kidney. So
So if you were to use an intravascular ultrasound and not OCT,
Blood is not a problem.
you would still use the guide wire.
Of course.
You would still use your angiography camera.
Yes. Because of this, the OCT is so full of information. It shows you this section after stenting. It's a large metallic something which at the edges dissects the coronary artery wall. For the let's say establishing that there is no dissection, there is no let's say possibly dangerous dissection. At the end of the procedure, we used to need, if you don't do the OCT, we would need extra projections, so extra maybe 30 millimeters of contrast agent, but they try to prove it that as the very last image, as a control, as a checkup that your acute result, post-procedure result is very good. If it is done with the OCT, maybe you can skip all the other 2 or 3 injections. So we call it final NGOs. If we do it, and maybe we can spare with the OCT, we can spare in the end 20 meters of contrast agent. And they try to prove it, but it needs maybe 10,000 patients to prove this kind of things. But when a new methodology proves, and it is still safe, proves to be safe and effective in any kind of aspect, then this level of indication goes up from 2B to 2A, and then it is considered to be a must. So for all the companies, these investment of giving to the cath labs maybe 3,000 units of catheters for free, in the long term it pays off if the indication of the use gets to a higher level. So.
And do all students, medical physics here, they see the OCT?
Yes, sometimes they come and see, but it's there is no everyday connection. So, thank you for your attention, and at 3:45. We try to prepare the patient. You also have to get prepared by changing your clothes and wearing the lead aprons, because X-ray we use, you will see that. I don't know how rapidly we will proceed with the patient. Always changing. Maybe one stent implantations together with OCT takes only 40